I'm Anthony Harries, and I'm here with my friend and colleague Ajay Kumar from India, and we're going to give you two examples of how operational research can be used to change policy and practice. Just to remind ourselves of the guiding principles in setting an operational research agenda, we define program objectives, we identify constraints or challenges that prevent those objectives being met, and then we ask research questions around those constraints. So I'm going to talk first about tuberculosis control in prisons in Malawi. From 1999 to 2004, Malawi had a 5-year TB program with 6 principal objectives shown on this slide. The second objective was to improve and sustain equity, meaning fairness, in the process of TB care. So if we look at this program objective, equity and TB care, one of the constraints, one of the challenges was that we had many prisoners being admitted around the country with tuberculosis. It seemed that they were a vulnerable population, and a general research question arose. Very simply, is TB transmission particularly high in prisons? We now know that this is, of course, the case, but at that time we didn't know about this in Malawi. And so a specific research question was asked: what is the prevalence of TB amongst prisoners in the largest prison in the country? Now, we did some important preparation before we embarked on this research. First of all, we obtained agreement from the Chief Commissioner of Prisons that we could conduct this study. We also obtained agreement from the judicial authorities. So the Chief Commissioner said, after a period of negotiation, please conduct this study, and importantly, when the study is completed, please present the findings to me and my staff. Now, I'm not going to go into details about the study, but suffice to say this was conducted between the 20th of May and the 26th of July 1996. Very simply, we decided that any prisoner who was coughing for more than 1 week would submit sputum specimens for smear microscopy to identify smear-positive pulmonary TB. And we did an active screening of prisoners from cell to cell. We went to a cell. We identified who was coughing. We basically identified those who were coughing for more than 1 week. We got them to submit sputum specimens, and we investigated thereon. Those who were smear positive were registered and treated. Those whose sputums were negative were then managed according to the Malawi National TB Program algorithm, with a chest x-ray, with antibiotics, and a decision made about whether or not they had smear-negative pulmonary TB. These are the results. We had 14 prisoners already on TB treatment. 900 prisoners, 70% of the total number, were screened for tuberculosis. You might ask, why did we not screen everybody? Well, as we went from cell to cell, some prisoners were out doing community service in the fields and could not be investigated. We diagnosed 18 prisoners with smear-positive pulmonary TB, 15 with smear-negative pulmonary TB. We also offered HIV testing to the TB patients and found that 75% of those tested were HIV positive. The prevalence of tuberculosis in Zomba Central Prison, the largest prison in Malawi, was 5%, 47 out of 900. This is a very high prevalence. So our conclusions from this study were threefold. Firstly, there was a high prevalence of TB in the central prison. There was a strong association with HIV, and it was apparent to us during this study that there was no good TB control system within the prison. Now, I want to describe for you the 4 basic steps that led to changing policy and practice and setting up a national TB control system in Malawi. Firstly, write up and disseminate findings. We completed this study in August 1996, By November 1996, we had written up the study as a report and also as a draft paper for scientific publication. In December 1996, we arranged a meeting with the Chief Commissioner of Prisons. He was very impressed with the study. He agreed to allow publication of the results, and he essentially gave instructions to the National TB Programme and to the medical staff in prisons around the country to do something about TB control in Malawi prisons. In November 1997, you can see that we published this paper in The Lancet, but in fact, long before that paper was published, we had begun to do things, changing policy and practice. So, to summarize this, firstly, you must move fast at the end of the study with writing up your results. Don't wait 6 months or 12 months, because by then you will have forgotten what you were doing. Ensure dissemination of the findings to the people who make decisions. And here, the Chief Commissioner of Prisons was the one who made decisions. Finally, publish in a peer-reviewed journal, because although the verbal communication with the decision makers may enable you to make policy and practice, this improves the credibility of the findings to have it peer-reviewed and published in a journal. Second, ensure the topic becomes part of the TB programme, objectives, plans and budgets. So in the 6 months from January to June 1997, we included TB control in prisons as an objective of the National TB Programme, and we put it under the programme objective Improving Equity. We in fact had no money to do this, so we persuaded our donors to shift budget lines so that we had a budget line for TB control in prisons. And then in November 1997, we kicked off with our first activity, which was a meeting between the National TB Programme and prison medical staff. A formal meeting, we looked at data, we did a report, and we sent those minutes to the Chief Commissioner of Prisons and to the Secretary for Health. Now, I don't know whether they ever read these minutes in great detail, but the fact that we sent these minutes to the Chief of the Prisons, the Chief of the Health Service, meant that people paid attention to these meetings, paid attention to what was asked of them, because ultimately the findings would go to the big chiefs, the big directors of each of their programs. So again, to summarize here, make sure that your topic then is integrated into the planning and objectives of the program. You have to identify funding to support the activity and ensure that there is leadership and people at all levels understand what is needed to be done. Then you need to build the screening, the monitoring, the evaluation, the accountability into the new activity. So between 1999 and 2002, this shows you some of the key activities. All new prisoners, when admitted to a prison, were screened for tuberculosis, and all inmates who developed symptoms of TB, cough, weight loss, coughing up blood, night sweats, fever, would be reported to the chairman of the prison cell and would be investigated accordingly. And we set up a good monitoring, recording and reporting system within the prison. Secondly, the meetings every 6 months occurred between National TB Programme and prison medical staff to review the data and look at progress. Thirdly, we ensured that during regional TB officer supervision of the country, they came to visit the prisons in their catchment area. So this became part of the National TB Programme quarterly activity plans. We invited prison medical staff to the annual TB meetings and our training sessions, and then we also got the NGOs, the non-governmental officers and non-governmental organisations involved in helping with prison TB control in the districts in which they worked. So very simply here, we need to support the new activities by making these a part of the National TB Programme routine activities. And finally, we need to publicise this new programme work in meetings and in papers and continue doing operational research. So following our Lancet publication, we had a publication looking at 5 years of prison TB control in the country. You can see 130,000 prisoners admitted to the prisons, 11,000 plus having a cough more than 1 week, a number having smear-positive pulmonary TB, smear-negative pulmonary TB, and extrapulmonary TB, and a cure rate that we weren't very happy about of 62%. And this was written up in the International Journal of Tuberculosis and Lung Disease. Then Mr. Banda did a study looking at the national prevalence of smear-positive pulmonary TB in Malawi amongst prisoners, basically going around 18 of the 22 prisons, looking at who'd had a cough for more than 1 week, who had submitted sputum, and who had smear-positive pulmonary TB and smear-positive pulmonary TB, which was 0.7% prevalence. And this again was published in the International Journal of Tuberculosis and Lung Disease. And finally, Mr. Canyareri did another study reporting on surveillance of TB in Malawian prisons in 2007. This took a little while to get published, but nevertheless looked at number of new prisoners admitted in 1 year, those with a cough more than 1 week, and then looking at those who were diagnosed as having smear-positive pulmonary TB, smear-negative pulmonary TB, and extrapulmonary TB. And what was good was between when we first started and this survey, the cure rate had definitely improved from 62% to 73%. I'm now going to hand over to my colleague who's going to tell you about an operational research study of screening TB patients for diabetes in India.
I'm going to take you through an example of operational research that happened in India, and this is about screening TB patients for diabetes mellitus. Just to give you a bit of a background here, it's well known now that diabetes mellitus increases the risk of TB by a factor of 2 to 3, and there have been many systematic reviews by Stevenson et al., Gion and Murray et al., and several studies thereafter which have confirmed that diabetes is a clear risk factor for tuberculosis. And not only that, there is some evidence that poor glycemic control among diabetes patients further worsens the risk of tuberculosis. And in addition, what's not shown in this slide but is now a well-known fact is that people who have both tuberculosis and diabetes mellitus have poorer outcomes. There is a delay in sputum conversion, there is an increased risk of death, and there is an increased risk of relapse from tuberculosis. Now, to address this looming co-epidemic of tuberculosis and diabetes, the World Health Organization and the International Union Against Tuberculosis and Lung Disease put together a framework which details a public health approach to addressing diabetes and tuberculosis. And this document was launched in August 2011. And there were several recommendations that were made in this particular document. And if you look at this, this is modeled in similar fashion as akin to the policy document on TB-HIV collaboration. The same 3 main steps: established mechanisms for collaboration, which included setting up means of coordinating between diabetes and TB programs, conducting surveillance of TB among people with diabetes, conducting surveillance of diabetes in people with TB, and conduct joint monitoring and evaluation of these activities. The second important one was to detect and manage TB in patients with diabetes, and the third one was to detect and manage diabetes in patients with TB. So the key activity, if you look at this, is a bi-directional screening for tuberculosis and diabetes. And in this case study, I'm going to discuss with you on one direction, which is screening TB patients for diabetes. Now, we chose 2 countries, China and India, to test this. Although there was a recommendation by WHO and the union that bidirectional screening has to be done, but there was no guidance as to how it should be done. how it should be implemented, how the recording and reporting should be there, how it should be monitored. These things were not clear. So, with support from the World Diabetes Foundation, a nationwide multi-center operational research study was designed in 2 countries, China and India. And the reason why we chose these 2 countries was that the burden of TB and diabetes these 2 countries top the burden in TB and diabetes. China is number 1 in diabetes, number 2 in TB, whereas India is number 1 in TB and number 2 in diabetes. So it made good sense that we test this in these 2 countries. Let me take you through the process, I think, which is an innovation in itself. The first thing that we did in these 2 countries was to hold a national stakeholders meeting. So in this meeting, all the important stakeholders who are involved in both tuberculosis control as well as diabetes were brought together under one roof. And this included national program managers of TB program, the diabetes program, people who were involved in implementation in the field, people who are working for research institutes in both tuberculosis control and diabetes, clinicians, all sorts of important stakeholders were brought together. And a consensus was achieved as to how this operational research needs to be implemented. And once a protocol was agreed upon, then we had a training program for all the people who are involved in the implementation of the research. And followed by that, for the period of January to September 2012, the screening was actually implemented, and I'm going to tell you exactly how it was done. This was followed by a review of all the activities and data, and it was again followed by another national stakeholders meeting where the results were presented back to everyone involved. So the protocol itself was very simple. It was about screening TB patients for diabetes mellitus. So every TB patient was asked one simple question: do you already know that you have diabetes? And if there is a known diagnosis of diabetes and the patient is already on treatment, it was simply documented in the registers. For those who did not know whether they had diabetes or not, then we went ahead and screened those patients with a random blood glucose test. And if the value of the random blood glucose test was more than 6.1 millimoles per liter or more than 110 milligrams per deciliter, then they were asked to come back the next day in a fasting state for a fasting blood glucose test. And if the fasting blood glucose was more than 7 millimoles per liter or more than 126 milligrams per deciliter, then we made a diagnosis of diabetes, and such patients were referred for further care and treatment of diabetes. Now, these are the results from India. This study was done in a multi-center fashion. So we had this study implemented in about 8 tertiary care institutes and more than 60 peripheral health institutions across the country. And these are the results. We had about 8,000 plus patients, tuberculosis patients, totally registered and enrolled during the study period. And of them, about 8% already had a diagnosis of diabetes mellitus and they were already on treatment. So among the rest who needed to be screened with random blood glucose, about 98% actually got screened with random blood glucose. And among those who had a value of more than 110 milligrams per deciliter and needed to be screened with fasting blood glucose, about 95% of them actually got screened with fasting blood glucose. Now, as a result of which, we found another 5% who were newly diagnosed with diabetes. So this gives us a total prevalence of about 13% of tuberculosis patients who had diabetes mellitus, and more than 95% of them were actually linked up to diabetes mellitus treatment services. Now, there are two key things to take away from this. Number one, I think there was a high acceptability of testing. 98% getting screened with RBG and 95% getting screened with FBG. So there was a high acceptability. Number two, there was a high prevalence of diabetes mellitus. Nearly 13% had diabetes and 5% were actually newly diagnosed for this by this screening effort. Now, these results were very, very appealing, and this was presented back to the national program managers. The TB program manager, as soon as he saw the results, was very clear in his mind that this means that it's a high yield activity and we need to have this implemented across the country. So a policy decision was made that all TB patients in India have to be routinely screened for diabetes mellitus. And a government order was immediately passed. Now, I want to make note of two things here. One, that this was an immediate policy decision that was taken. And in fact, if you look at the date of this particular government order, it was dated 21st September 2012. In fact, when the study was still ongoing. So a policy decision was made based on interim results even before the study was completed, which was due for completion by the end of September 2012. And if you look at the publication, we of course wrote this up and published in Tropical Medicine and International Health. It got published much later in May 2013. So one of the things that happened after the research was done and after the policy decision was taken was to make changes into the routine recording and reporting system so that this particular activity could be monitored. And this is the change that happened in the TB treatment card that was used across the country in India. New fields were introduced to capture diabetes status, just to capture whether a person has diabetes or doesn't have diabetes or it's unknown, and few other details of the screening process. The same field was also introduced into the TB register, capturing the status of diabetes. And simple parameters were added for routine reporting in quarterly TB reports. Number of TB patients registered, which was already being reported, and the two other indicators that were included, number of TB patients who were screened for diabetes mellitus, and of those, how many were diagnosed with diabetes mellitus. And these are the changes that happened in practice. And if you want to learn in greater detail about the processes and the innovations that were involved, which led to this rapid national policy change, you can read this particular article which was published in Public Health Action in June 2014. To conclude, I think with the research, any research that you undertake, just think ahead as to what you want to achieve. It's not just about publication. There is some policy change, some practice change that is always expected. And then ensure that research is done in close collaboration with program and the decision makers. And this was crucial. If you notice both the examples, whether it was prison TB control in Malawi or TB diabetes activities in India, it was all done in close collaboration with the people who matter, the national program managers in TB program, in diabetes program, head of prisons, head of TB control program, and involve the decision makers at the beginning rather than at the end. Thank you very much.